Okay, so we can start the session. Today I'll be taking arthritis and starting the session with rheumatoid arthritis. Now, this condition is a disease of synovium. Okay, so it is a disease of synovium, and the pathology is that there is hypertrophy of synovium, and this is associated with formation of granulation tissue over cartilage, right? So there is formation of granulation tissue over cartilage, and this particular uh, process leads to the formation of pannus, which destroys the surrounding area. So please remember the word pannus here. Okay, now this is an autoimmune condition, and when we say the word autoimmune, it means the immunity is directed against its own tissues, and of course there is inflammation of the synovium, right? So autoimmune condition with inflammation of synovium, and HLA which is associated with this condition is DR4. Now this is a classical image of a case of rheumatoid arthritis, and most of the time the word which we characteristically use here is symmetric arthritis. Clear? So we use the word symmetric arthritis because most of the time the lesions in both the hands, they are identical. Clear? So identical lesions or identical deformities in both the hands, and therefore we use the word symmetric arthritis. So there is symmetric, you can say, arthritis, and in terms of pathological description, there is hypertrophy of the small joints of hand, characteristically especially the metacarpophalangeal, right? So metacarpophalangeal joint, right? So these are the metacarpophalangeal joints here. These are the MCP joints. Clear? So there is characteristic involvement of the MCP joints. In fact, MCP joints are the commonest joint involved in this pathology of rheumatoid arthritis. And there is involvement of proximal interphalangeal joint as well. So proximal interphalangeal joint as well, right? And if I show you, this is the proximal interphalangeal joint. Clear? So this is the proximal interphalangeal joint. So these are characteristically involved in rheumatoid arthritis. Remember, there is no involvement of the distal interphalangeal joint. So these are the distal interphalangeal joint. Clear? So there is no involvement of distal interphalangeal joint. You can say not involved. So MCP and PIP, these are involved, and DIP, that is distal interphalangeal joint, it is uninvolved. Now this is very important because at times patient can have osteoarthritis of the hand, and this actually help us in clinically differentiating the two entities, right? So this is very important to remember. So there is no involvement of the DIP, but never distal interphalangeal joint. So please remember this much, okay? Now, patient, usually a young lady, she comes to us with complaints of morning stiffness of hand, obviously. So when she comes and she complains that whenever I'll get up, I'll feel as if my joints are stiff and it is very hard for me to move fingers. But yes, as I am involved in day to day activities, the stiffness gradually subsides. So, morning stiffness is very important here. And as the disease progress, there is development of deformities, right? So, usually there is ulnar deviation of fingers. So ulnar deviation of fingers, right? So if I draw here, the ulnar deviation is something like this, towards this side, okay, towards this side. So the fingers, they'll be bent towards ulna, or you can say medial side. So this is because the deformities, they tend to come. Now on X-ray, you will see few important points. One is, because it is an inflammatory pathology, so the classical description is juxta articular osteopenia. Osteopenia. Juxta means surrounding, okay. Articular means joints. Osteo is bone. Penia means you can say rarefaction, right? So on X-ray, if you see, you will see black shadows, right? These black shadows, these are all osteopenic areas. It means because of inflammatory pathology, there is excess resorption of calcium, okay. So this black shadow is all juxta-articular osteopenia. Fine. So this is one important thing. Now second important thing is, because there is destruction of the cartilage, so there will be narrowing of joint space, because the articular ends of the involved bones, they will come closure because the intervening disc dies off, so it leads to narrowing of joint space. And sometimes we can see marginal erosions as well, right? So these are few important X-ray findings of rheumatoid arthritis which everyone should know. Then the dangerous complication at times is at C1 C2 subluxation. So C1 C2, atlantoaxial subluxation, right? Now treatment wise, we need to give analgesics, we can give anti-inflammatory steroids. Then there is one class of drug which we use, this is known as DMARDs or DMARDs. So this is disease modifying anti-rheumatoid drugs. Clear? So disease modifying anti-rheumatoid drugs, and it includes methotrexate, chloroquine, sulfasalazine and gold salts. Now the condition is affecting usually females in the age group of, you can say, 25 to 35 years. So this is a classical presentation of rheumatoid arthritis, and we have already discussed that it involves mainly two joints, MCP and PIP, that is proximal interphalangeal, right? So there is no involvement of DIP, that you has to remember. No DIP involvement in the disease process. Now we already discussed that there might be development of certain deformities, particularly in relation to hand. There are two important deformities which you should remember. One is the swan neck deformity, and another is the buttonholing, which is also known as boutonniere deformity, right? Also known as buttonholing. Now the basic difference in between the two, you can simply say that they are opposite to each other, and we look at the characteristic posture at PIP, that is proximal interphalangeal joint, and DIP, that is distal interphalangeal joint. So if we talk about the swan neck deformity, you can see here this is PIP and this one is DIP. Similarly, in boutonniere, you can see this is PIP and this is the DIP, right? So in boutonniere deformity, if you see at PIP, that is proximal interphalangeal joint, there is flexion contracture, right? So there is flexion. But at DIP, you can see that there is extension. So there is extension of DIP and there is flexion of PIP. Now simply reverse it and you will get the swan neck deformity. So there is extension at PIP and there is flexion at DIP. Clear? So just opposite to each other and very easy to remember. If you remember one, you can decode other. Now in some patient, we can see that apart from the joint, there is involvement of some other tissues as well, like cardiovascular system or other tissues. So this is known as extra articular. Extra means outside. So outside the bony system, there might be involvement of other systems, and these are especially seen if a person or a patient is positive for RA factor, right? So RA factor is not diagnostic. In one way, you can say that it is diagnostic, prognostic, and it will indicate that the person might have a grave course ahead, right? So this is RA factor, which is actually IgM and autoantibodies to the Fc fragment of IgG, right? So this is in short about rheumatoid arthritis. Then we move on to osteoarthritis, and again the word arthritis is wrong here because there is no inflammation as such. This is simply a degenerative condition, and the cartilage which is covering the articular ends, it actually degrades, right? So here, if this is the, we have the articular cartilage, something like this, which is hyaline variety, and it degenerates either primarily or it can because of some infective or mismanaged intra-articular fracture, right? So this is degeneration of articular cartilage. So only big joints are involved here, mainly as in comparison to rheumatoid arthritis, which primarily involves the small joints of the hand. Now it can involve two big joints, like one is hip joint and another is knee joint. Now hip osteoarthritis is commonly seen in Western world, but if you talk about our Indian setup, here we see osteoarthritis of the knee joint very commonly, right? So hip joint osteoarthritis is very commonly seen in Western world, whereas in Indian setup it is knee joint. Now here you should remember one thing, that it does not affect the metacarpophalangeal joint, and we just discussed that MCP joint is the commonly affected joint in rheumatoid arthritis. So it is commonly affected in rheumatoid arthritis. So this is again one very differentiating point between the two entities. MCP joint affection, rheumatoid arthritis. MCP joint not affected, you can simply say it is more in favor of osteoarthritis. So this is how sometimes if we are dealing with the case of if a case of arthritis of hand, this is how we can clinically reach up to a diagnosis whether it is rheumatoid or osteoarthritis. Now in osteoarthritis, there is formation of nodes on PIP and DIP. right? So in the in case of DIP, these nodes are known as Heberden's node, right? So this is Heberden's node. Whereas in case of PIP, this is known as Bouchard's node. So different areas have got different different names for the nodes. So I think you can clearly see the nodes very nicely, right? So these are Heberden's and Bouchard's node. Now coming to the X-ray, what we will see. Now normally what happens in a joint, especially the articular surfaces are covered by cartilage. So something like this, right? So as such, there is no space between the two articular ends, but since there is this articular cartilage which is covering the bony surfaces, which is not visualized on the X-ray, so we will see a bony gap. Now this bony gap is because of this articular cartilage, and once this articular cartilage will degenerate, obviously the bones will come closure, and that is perceived as reduction in joint space. Clear? So one important thing is reduction of joint space, and the reason is that the intervening cartilage, which was actually giving impression of joint space on X-ray, it goes away from between the two articular ends. So reduction in joint space because of degeneration of cartilage. Now apart from this, at times we can see there is calcification along the soft tissues of the articular ends, and that this is known as bony spur or osteophyte. Clear? So this is osteophyte, or just looks like a bony spur. Apart from this, we can also see sometimes extreme whiteness, right? So if you see here, you can see extreme whiteness here, right? So this white line is known as sclerosis. So since it is lying below the cartilage, so it will be known as subchondral sclerosis. Okay, so it is subchondral sclerosis. So these are three important points which you should remember for radiological findings of osteoarthritis. So this white line is all subchondral sclerosis. Okay, so if I give it number 4C, so here you can remember it, right? So this is subchondral sclerosis. Now there are two varieties. One is of course primary, where there is no exact cause, so no known cause, and this is the one which we see more commonly in the clinical practice, so most common type. But sometimes there is development of osteoarthritis because of some underlying cause, then it is known as secondary. So it can be because of management of poor management of intra-articular fractures, or sometimes there is inflammatory pathology like rheumatoid arthritis. So now this word is very important here, intra-articular fractures, and therefore we always say that these should be managed by ORIF, that is open reduction plus internal fixation, because we just want to maintain the articular congruity, and so as to make sure that there is less friction over the cartilage and it doesn't degenerate. So intra-articular fracture management is extremely important, otherwise later on patient might go into osteoarthritis. Now clinically, the classical word is asymmetric arthritis, and you have to compare it with the word symmetric arthritis of rheumatoid arthritis. Then there can be joint crepitus if you keep your palm over the joint and if you tell the patient to move the joint, you can feel some sounds. So those are known as crepitus. So sounds can be felt, crepitus. And then there may be pain along the joint line. This is very important clinically, and initially it is with activity only, but later on when the cartilage damage is too much, the patient can have the pain even at rest, and this is the point when we have to go for surgical intervention. Now coming to management, we can start with NSAIDs, that is non-steroidal anti-inflammatory drugs, and the drug of choice here is diclofenac. You must be knowing the name of Voveron. So because it gains entry into synovial fluid, so attains concentration in synovial fluid, so we take it as drug of choice here. Then if this doesn't work, then sometimes we can try intra-articular steroid injections within the joint. But if the person has pain 24 hours, then the final thing is total joint replacement, right? So it can be hip or it can be knee. And here you can see this is a X-ray of total hip replacement, THR, right? So we have to remove both the components, the femoral component and the acetabular component. So both the components are removed here. So this is in short about osteoarthritis. Then moving forward to ankylosing spondylitis, one of the extremely important topics, and there is no paper without picking one question from this segment. So it is also known as Mary-Strumple disease or Bactrius disease, and it is associated with HLA B27, right? And there is one classical term, and this is enthesitis. And enthesitis means the point over the bone where there is attachment of any tendon, like the back of the heel, where there is attachment. If suppose this is calcaneum, this is tendo Achilles, which is the tendon of gastrocolius muscle, and this area is known as enthesis. So such areas become extremely painful, right? So this is known as enthesitis, and a very important clinical feature of ankylosing spondylitis. Okay, so this is enthesopathy or enthesitis, very commonly related to heel. It usually affects young adults around the age of, you can say, 25 years, and classically patient comes to us with back pain, right? Patient will say that I am having low back pain, but the classical presentation is morning stiffness, right? Morning stiffness. So when the patient will say to us that when I'll wake up in the morning, I'll have extreme back pain, and as I am involved in day-to-day activities, the pain subsides slowly. So that is the classical presentation. So in simpler words, what we say, that the pain, it comes with rest and it goes away with activity. So if the patient is sleeping or sitting somewhere, so after some time he will have back pain or enthesitis kind of pain, and as he is involved in the activities like walking or going here and there, the pain will subside. So this is the classical presentation, and when the patient says this much only, we are in a state of mind that yes, he might be a case of ankylosing spondylitis. And over a period of time, there is fusion between the vertebral bodies, and therefore there is limitation of spinal movements. So there is a restriction, or you can say limitation of spinal movements, so flexion, extension. Nearly 33% of the cases of ankylosing spondylitis, they can have an attack of acute anterior uveitis, right? So nearly 1/3 of the patient might experience this acute anterior uveitis. Some might have inflammatory bowel disease as well. Then coming to the x-rays, what we can see here, of course, one classical finding is that there is syndesmophytes between the vertebral bodies, and this leads to the classical bamboo spine. Okay, so this is the classical bamboo spine. Fine. So this is bamboo spine. Secondly, there might be involvement of the sacroiliac joint, and in fact this can be one of the earliest joint to be involved here. So what we'll see haziness in the sacroiliac joint, and that suggests that there is inflammation in the sacroiliac joint. Thirdly, we can see squaring of vertebra, right? So we can see squaring of vertebrae also. So the vertebra, if you can see here, they looks like a square. So this is squaring of vertebra. Now, unfortunately, there is no specific therapy for this. We can, although the pain can be relieved by endomethacin. Endomethacin, it relieves pain, but it does not stops the underlying pathology. And yes, since there is restriction of movements, we can tell the patient to continue chest or spinal physiotherapy so as to gain the movements as much as possible. So this is in short about ankylosing spondylitis. Then we move on to psoriatic arthropathy, which is associated with psoriasis, as the name suggests, and there is classically involvement of distal interphalangeal joint. And the another term is arthritis mutilans. And what we see in X-ray, we can see pencil in cup deformity, right? So there is tapering of the tip of middle phalanx, and there is broadening of the base of distal phalanx. So this is known as, this becomes pencil and this becomes cup. So there is pencil in cup deformity. Clear? And characteristically we can see telescoping. It means the fingers can be invaginated into each other. So that is telescoping because of this articular damage. Then moving forward to gout, this is one of the easiest conditions to diagnose in orthopedics. The moment you look a patient with pain, redness, swelling of the first metatarsophalangeal joint, or in simpler words, great toe, you can straight away jump to the diagnosis of gout. And there is deposition of monosodium urate crystals, because now urate means, urate is uric acid, and in this condition there is hyperuricemia, right? Emia means in blood, uric is uric acid. So there is raised uric acid level in blood. Therefore we will see the monosodium urate crystals in joint. Now the condition is quite obvious. It is the metatarsophalangeal, and this is obviously great toe or big toe. Clear? And we can classically see here there is swelling in raised temperature, and there will be tenderness, all features of inflammation. This all suggests inflammation. Clear? Now we can do synovial fluid examination and we will see a negatively birefringent urate crystals. Okay, so we can see these yellow colored crystals. These are all urate crystals which are negatively birefringent, and if you look at the shape, these are needle shaped, pointed on both the ends. So needle, or you can say rod shaped. Okay, so very easy to identify under polarized light. Now acute attacks, you can give painkillers, NSAIDs, that is non-steroidal anti-inflammatory drugs, or you can give colchicine. Remember, allopurinol has to be given only in chronic cases. Here it is the drug of choice, and I think most of you must be knowing that it is an inhibitor of the enzyme xanthine oxidase, which is involved in the production of uric acid. Right? So this is gout. Now there is another condition which confuses us, and that is pseudo gout. Now here there is deposition of calcium pyrophosphate. Right? So there is deposition of calcium pyrophosphate crystals. Okay, and it affects the knee joint commonly, as in comparison to gout, which is affecting the great toe or foot. Now this can be seen in hypothyroidism, and when we do synovial fluid examination, we will see positively birefringent rhomboid crystals. Right? So this is calcium pyrophosphate crystals which are rhomboid shaped. Okay, so if you look in the image, these blue colors crystals are all calcium pyrophosphate. Okay, so rhomboid, or at times they can be of different shape. So blue color crystals, they are all calcium pyrophosphate. Right? So these are three important differences between gout, pseudo gout. One is about the part of the joint which is involved. Second is about, okay, we can just write it down. So if we write gout, the another entity is of course the pseudo gout. Right? Now if we talk about the joint involved, then here it is foot, you can say. This is knee. Then if we talk about the substance or the chemical, then here it is monosodium urate, here it is calcium pyrophosphate. And third, if we say about the polarizing, the presentation in polarizing light, it is needle negative because it is appearing yellow, and this is rhomboid and positive birefringent. Right? So this is the basic difference between the two entities. So please remember, gout is always and always a very favorite for exam setters. Then coming to neuropathic joint disease, just few words. It is also known as Charcot's joint. And when we say neuropathic, it means the sensations are absent. Therefore, the patient will have so much of damage to the joint, and he is unaware of that because there are no sensations going from the joint, and therefore it is non-tender as well. So patient is unaware of this. He will simply come to us with a swollen deformed joint. So in fact he is coming to us for cosmetic reason, not for the pain or any other thing. He's just coming to us for cosmetic reason. Because of neuropathy there is no pain sensation, so it is almost non-tender. Clinically it is commonly seen in diabetes mellitus, though patient with leprosy can also present to us with this condition. So neuropathic joint disease, here the pain sensations are not carried. Then moving forward to hemophilic arthropathy. Now hemophilia A, this is because of deficiency of factor 8, and hemophilia B, this is because of deficiency of factor 9. So this is in short about pathology. The inheritance is X-linked recessive, and therefore the males are affected. So when you will see a case of hemophilia, you will always say that, you will always see that it is a male, and there is bleeding tendency, of course, and this bleeding usually occurs in joint, especially the knee joint, right? So you can see here there is classically involvement of the knee joint. Sometimes we can see bleeding in the muscles also. Okay, and one of the radiological features is widening of intercondylar notch of femur. Okay, so this is widening of intercondylar notch of femur. Right, so this is one important X-ray sign. Treatment, you have to replace the deficient factor, and involvement of joint might need aspiration. Then coming to alkaptonuria, I think most of you must have heard of this term in biochemistry. Now there is a deficiency of the enzyme that is known as homogentisate oxidase, right? And classically what we see, there is one term that is known as ochronosis, where there is dark pigmentation of connective tissues. So you can see here in the, you can see dark pigmentation, right? So ear cartilage, or even in sclera, you can see dark pigmentation here. So there is calcification of cartilage, and there is appearance of homogentisate in urine. And if you keep the urine sample for some time in air, it will turn dark, or you can say black. So that is very important for, that is a very important part of clinical history of alkaptonuria. Now treatment wise, we can give vitamin C to such patients. So this is enough for this session. I'll very shortly I'll come with another chapter of orthopedics. So till then, thank you, and keep on studying. Bye bye.